All right, it is right on 12 o'clock, so we'll go ahead and get started. I want to welcome everyone to the University of Colorado Medical Grand Rounds. I have no major Department of Medicine announcements for us today, just to highlight the upcoming Medical Grand Rounds. Next week is our annual Shark Tank competition. If you have not gone to that before, it is very fun. I will be one of the judges, and we'll be finding our new shark for 2022 with the best idea in the Department of Medicine. The week after that is our Meiklejohn Lecture, named after one of the first chairs of medicine here at the University of Colorado. We'll be welcoming Dr. Jeffrey Samet from Boston University to speak with us that day. As a reminder, you can claim CME and mock credit for all medical grand rounds this year, so please go ahead and do that. And I'll remind you to please use the Q&A feature to place all of your questions for Dr. Cruz, which the chiefs and myself will gather for the end of her talk for some conversation. Before I introduce our distinguished speaker, Dr. Deirdre Cruz, I want to mention that today is our Collins Lectureship, and this is a very special lectureship. Robert and Elaine Collins were longtime benefactors of many things in the Denver metro area, one of them being the Division of Renal Diseases and Hypertension. They were early pioneers in dialysis technology and equipment. They used a lot of their resources for good locally as well as around the world. And so this visiting professorship is sponsored by the Collins family. We are very thankful to them for providing us with this opportunity to host a visiting professor usually in the field of dialysis care within renal diseases and hypertension. And so the person that we are welcoming today is Dr. Deirdre Cruz. I told her I could do this in 1 to 2 minutes. It may be a solid 2 minutes. She is a remarkable physician and human being. She is currently a professor in the Department of Medicine in the Division of Nephrology at Johns Hopkins, with a joint appointment in the School of Nursing as well as the Bloomberg School of Public Health. She is also the Deputy Director of the Johns Hopkins Center for Health Equity and the Associate Director for Faculty Development in the Division of Nephrology at Hopkins. She received her MD degree from St. Louis University and then went on to do her internship, residency, and fellowship at Johns Hopkins Hospital. Her efforts to transform medicine in Baltimore and around the country truly are remarkable. Since starting fellowship, finishing fellowship, she has served or continues to serve in a number of important roles. She was the Gilbert S. Oman Fellowship in Biomedical Science and Population Health recipient in the mid-2010s through the National Academy of Medicine. She is core faculty at the Welsh Center for Prevention, Epidemiology, and Clinical Research. She's also associate faculty at the Center of Aging and Health, the Associate Director for Faculty Development in the Division of Nephrology, the Associate Vice Chair for Diversity and Inclusion in the Department of Medicine, and a number of other leadership roles. She has written or co-authored over 125 publications and has given an equal number of talks with an expertise in renal diseases, dialysis, transplant medicine, and then most importantly, as she'll tell us today, the intersection of renal diseases with race, ethnicity, social status, and many of the other societal barriers to excellent care. Her core area of research focuses on understanding and addressing disparities in the care and outcomes of chronic kidney disease. She's examined the contribution of social determinants of health, including race, poverty, access to healthy foods, dietary habits, and disparities in CKD, and has tested interventions aimed at mitigating these disparities. Her work has been continuously funded since the end of her fellowship. She is currently funded by a number of grants, a U01 having to do with community-based dietary approach for hypertensive African Americans with chronic kidney disease, an R35, 2 R01s, a K24 regarding patient-oriented research addressing disparities in hypertension and kidney disease, and an AHA grant to help lead the RESTORE trial, which has to do with addressing social determinants of health in hypertension. She is also a tireless teacher, locally at Hopkins as well as nationally. She shares her time as a mentor as well, having mentored over 100 fellows, residents, and students during her faculty years. And for her incredible work, she's received numerous honors. This started when she was awarded the Chapter Member of the Year for the Student National Medical Association as a medical student, all the way up into receiving the 2016 Frederick Brancati Excellence in Mentoring Award, the 2020 Mary Elizabeth Garrett Executive Leadership Program for Women at Johns Hopkins, and remarkably, the 2018 winner of the Frontier Award, which is the highest award that Johns Hopkins Hospital bestows upon any of its faculty in a given year. In addition to all of that, she's going to take her leadership skills, or has already taken those, to the American Society of Nephrology. She is currently the secretary, which means in 2024, she'll be president of that organization. It really is an honor, Dr. Cruz, to have you here with us as the Collins Lecturer today. Thank you for coming to the University of Colorado.
Wow, well, thank you so much, Dr. Connors, for that tremendously warm introduction. And I'm really deeply honored to be here, especially in light of the generosity of the Collins family in supporting this lectureship. And have to say, I've especially enjoyed the wonderful experience I've had getting to spend time with my colleagues here in nephrology. So thank you all so much for having me. I am going to be sharing with you all today a bit on the topic of addressing disparities in the burden, care, and outcomes of people with chronic kidney disease. And I really look forward to, in particular at the end, hopefully having a chance to engage in some discussion around both these disparities as well as how they may intersect with some of the fields that I know you all are conducting work in. And so our objectives for our time together today are going to be first to provide an overview of the profound disparities that we see in chronic kidney disease and some of the societal impacts of these disparities. We'll go on to discuss some of the potential root causes of disparities in CKD. And then finally, I'll highlight for you some of the opportunities to mitigate disparities in CKD, including some examples of some successful efforts in this regard, as well as some ongoing efforts. And so just to make sure we're sort of all referring to the same thing today, when we think about disadvantaged or sort of socially marginalized groups in relation to health disparities, here we're speaking of those groups that have been adversely affected systematically, experiencing greater obstacles to their health based on any of these factors really that are highlighted here on this slide. And those are going to include sort of based on those individuals' assignment to certain racial or ethnic groups in our society, their socioeconomic status, their religion, their cognitive or physical ability, their sexual orientation or gender identity, and really any other characteristics that have historically been linked to discrimination or exclusion from opportunity in our society. We're going to spend most of our time together focused on these sort of first two groups, thinking about racial and ethnic groups, as well as socioeconomic status with respect to these health disparities. And so what we see when we look closely at kidney disease is that disparities in kidney disease are quite profound. We know that Black or African Americans have 2.7 times the risk of developing kidney failure when compared to white persons. We know that Hispanic individuals have 1.3 times the rates of developing kidney failure as compared to non-Hispanic white individuals. And we know that these racial and ethnic disparities that we observe are not fully explained by genetic factors. For example, we know in the kidney disease space that particular gene variants at apolipoprotein L1 have been associated with greater risk of developing kidney disease and having it progress to kidney failure among people who have African ancestry. But we actually continue to see disparities comparing people with African ancestry, for example, Black Americans, to white individuals, people with predominantly European ancestry, even when we compare those Black Americans who have the low-risk gene variants of APOL1, really highlighting that, again, that these disparities are not fully explained by gene variants, including APOL1. We also know that people who have low levels of educational attainment or who have low income levels have higher rates of chronic kidney disease. And a major challenge in our field is that when we look at kind of awareness of chronic kidney disease, what we see is actually that 9 in 10 people who have CKD are actually not aware that they have it. And unfortunately, awareness has been documented to be lowest even among several high-risk populations, those groups that we would be particularly concerned about with respect to their risk of progressive CKD to kidney failure. And so in some work that we've done to really track some of these disparities, what we found is in using data from the National Health and Nutrition Examination Survey, or NHANES, When we look at really a nearly 3-decade period, what we found is that these gaps in chronic kidney disease prevalence have continued to sort of persist when we look across socioeconomic status groups, really over these 28 or so years. And in particular, what we noted was that CKD prevalence almost doubled among Mexican American individuals between the sort of earlier time period, 2003 to 2004, up until the more recent time period that we examined of 2015 to 2016. And importantly, other racial or ethnic and socioeconomic groups didn't experience appreciable increases in the prevalence of CKD, so they were sort of stable in that regard, but the gaps between these groups persisted. So really showing us that we really haven't made much in the way of gains in terms of narrowing or mitigating disparities that we see in terms of the prevalence of chronic kidney disease. And so I hope that all of us tuned in via this Zoom webinar today can agree that health disparities are inhumane. I think it's important to underscore that they are also quite costly. It's been estimated that $1.2 trillion is spent by our country in combined costs of health disparities and the subsequent deaths that occur as a consequence of health disparities. When we focus on racial or ethnic minoritized persons, and this is noted to be due to those individuals receiving inadequate or inequitable care. It's also been noted that around 30% of medical expenses that these populations incur are actually due to excess costs that stem from health disparities. And finally, and really I think an important area that really holds us back as a nation with respect to addressing these challenges is that the US actually spends less on social services than many of our peer countries around the globe. So here, thinking of our economic peers, and we are actually the only country that spends more on healthcare services than we do on social services as a percentage of our gross domestic product. And many scholars have argued that this is a really key driving force behind our continued observation of these disparities, as well as the fact that we don't enjoy the sort of health outcomes that many of our peers around the world do enjoy. And so a number of different models have been put forward to help us think about or sort of conceptualize the root causes of disparities that we see in kidney disease, here particularly focused on socially marginalized populations. This is a model that I like a lot because I think it really captures 3 major sort of basket areas when we think about these root causes. So I'll call your attention to the right-hand side of the figure here, where we see uninsurance status or underinsurance status and the numerous issues that can arise as a consequence. Here, thinking of course, limited access to healthcare just in general, but also potentially low utilization of appropriate healthcare services, which of course has implications for the identification and the sort of risk reduction when we think of clinical risk factors for kidney disease like diabetes or hypertension. And of course, those individuals experiencing this can go on and develop CKD itself and have that disease progress. In the middle of this figure are those issues that can stem from the experience of discrimination. And here thinking of the both the sort of psychosocial factors that can stem here. So including for many individuals, they may develop depressive symptoms as a consequence and can experience chronic stress and the neurohormonal implications of that experience of chronic stress. Often that type of stress can also lead to maladaptive health behavior. So thinking here of substance use disorders that may emerge. And these factors can then, again, ultimately have impacts on some of the more clinical types of risk factors we think of when we think of risk for kidney disease and can lead to kidney disease itself. On the far left-hand side are those challenges that can stem from residential segregation. And here in particular, thinking of racial residential segregation, where we can see then poor educational systems in many of these communities, overcrowding, exposure to environmental toxins, here important kidney disease space, thinking of things like lead exposure, which we know can raise risk of both hypertension and kidney disease in these populations. And we know that in many cases, these individuals living in these residentially segregated communities may not have access to healthful foods, which can have, again, impacts ultimately on their clinical risk factors for kidney disease and ultimately to progression of their disease. And so in our time together today, what I'd like to do is highlight these areas that have sort of in red boxes now here, including some work from my colleagues and I, really helping us to try to elucidate what these factors mean in the context of understanding disparities in kidney disease. So turning first to this area of healthcare access and also healthcare quality. So I'm certain that probably all of you are aware that over the past 2 years, questions have been raised about the very way that we even diagnose kidney disease, particularly for Black individuals in this country. And the fact that for the last 2 decades, we have used an equation that where a different report was made for an individual who was considered to be a Black or African American person as compared to a non-Black or non-African American person. And while certainly this topic has been more in the news in the last couple of years, there were both people inside and outside of medicine who were writing perspective pieces about this even prior to 2020. But certainly we did see an increase in these types of articles being published. I'm sharing a few examples here, including in the bottom right-hand corner, where what is being highlighted is an article from a medical student here from the University of Washington. And I think important to note that medical students in particular, I think, really caused many of us to question this practice. Because, you know, as those of you tuned in today know, that when we're teaching something, we are required really to have to explain, you know, why we do what we do, and that was no different for this case of this differential EGFR reporting by race. And so this led to the National Kidney Foundation and the American Society of Nephrology forming a task force to reassess the inclusion of race in diagnosing kidney disease. I was honored to be a part of this task force, where we ultimately recommended the immediate implementation of an equation, a CKD epidemiology collaboration equation that was refit without the inclusion of race, and we recommended that it be adopted in all laboratories across the U.S. I'd be curious to know if that change has been made in your system and what you've been finding sort of since then. We also did recommend national efforts to increase the use of cystatin C in sort of assessing kidney function as well. This equation that we recommended, I think importantly, was developed and sort of published in the New England Journal. And importantly, it had very good performance. So for all of the equations that were looked at here, these refit equations without race, 85% or more of the estimated glomerular filtration rate values that were generated for both Black and non-Black individuals were within 30% of measured GFR, which is what we're trying to estimate. And so it was really thought that these are good performing. These equations have good performance, and certainly there's hope that by using these new equations that we might at least mitigate the effects that the sort of systematic use of the previous equations that kind of overestimated, many people were concerned, overestimated the level of kidney function and maybe made us less likely to diagnose early chronic kidney disease among Black individuals. So there's hope that there could be an impact there. But certainly this is just one part of the many efforts that will need to be undertaken to fully mitigate the enormous and profound disparities we see in chronic kidney disease. One important disparity worth highlighting here in this space of healthcare access is this issue of timely referral for nephrology care. One of the things that we see in the US is that Black, Hispanic, and Asian patients are less likely to receive nephrology care within the year, the 12 months prior to those same groups requiring initiation of dialysis. And in work with my colleague, Dr. Tangela Purnell, we looked at trends in this sort of finding, this timeliness of nephrology care, and found that after looking at sort of over a decade of data here, this is using Medicare data to look at this. What we found was that for really Black, Hispanic, and Asian groups, but in particular for Hispanic individuals, they were about 39% less likely to be seen by a nephrologist for at least 12 months prior to having to initiate dialysis. And for those that are not nephrologists that are wondering, well, why does it matter how long people are seen? During that year in particular, that ahead of when someone is requiring the start of kidney replacement therapy, this is a time when we can prepare patients for their treatment options. We can, in many cases, we can even try to mitigate their progression. And we can make sure that they know that home dialysis is an option, transplantation is an option. And it's been shown in other studies that late referral, so those people that are seen just within the few weeks and sometimes even just days of needing to start dialysis, those are going to be people that are going to be less likely to really be able to access some of these either home therapies or transplantation. Now, in the same study, we were curious, and I'm sure many of you probably are as well, that are these racial and ethnic disparities that were being observed around timely nephrology care, is it really just driven by what we know to be disparities in insurance status? And so importantly, when we then adjusted or accounted for disparities in insurance coverage, we did see an attenuation in our findings that did not include that adjustment, but we did continue to see the persistence of disparities, particularly for Hispanic individuals. So where they continue to be 10% less likely to have received this timely nephrology care, really arguing that there's more to the story than just the insurance piece. Now, I know that many of you here work at the VA here in Denver, and importantly, some colleagues have done work looking at this question of timely nephrology care among the veterans population, the Veterans Administration, where we know that the access is equal, right? And so among these individuals, and what they actually found in this study by Dr. Suarez and colleagues was that here in the veteran population, the Hispanic and Black veterans were actually more likely to be seen and sort of referred to see a nephrologist than were the white veterans. Yet the Hispanic and Black veterans were still more likely to experience progression of their kidney disease. And I think an important sort of take-home message from this study was that other factors outside of nephrology care are likely really driving a lot of what we see in terms of racial and ethnic disparities in CKD. So turning to this issue of discrimination. So the sort of topic of perceived discrimination in kidney disease is one that is certainly understudied, but we know from other areas, particularly around cardiovascular outcomes, including hypertension, that this experience of perceived discrimination can have health implications. My colleagues and I were able to provide one of the earliest reports of this relationship between perceived discrimination and change in kidney function by using data from a Baltimore-based study called the Healthy Aging in Neighborhoods of Diversity Across the Lifespan study, or the HANDLE study, which is quite a mouthful, so we'll use handles from here on. And here what we did was to examine self-reported perceived racial and perceived gender discrimination in this population across 5 distinct situations. So these were in the setting of being in school or sort of seeking an education, in the setting of seeking out employment or already actually being in the workplace, even in the home setting, or when seeking out medical care. And we also here examined a general measure of the experience of discrimination that's been looked at in a number of other studies. And I'll share with you kind of our major findings, which were that among white women, a high level of experience of discrimination was associated with a lower level of baseline kidney function, so a lower estimated GFR here at baseline in this study. And among African American women, both perceived racial and gender discrimination were linked to a lower level of follow-up kidney function. So when we then sort of assessed, here in this study was after about 5 years of follow-up that we looked at this, really sort of showing this link. Now, others have looked at similar, sort of a similar question since then. Here, this was a study done within the Jackson Heart study, which is a study of African Americans living in the Mississippi Delta region, looking at, I'm sure you can tell from the name, looking at a number of different cardiovascular outcomes. And in this analysis, Dr. Diamantidis and colleagues looked at around 3,200 participants of the Jackson Heart study who already had here either chronic kidney disease, diabetes, or hypertension. And they examined kind of a battery of different measures, and including sort of sociodemographic and sort of comorbid disease burden, and found that in this population that having a low level of trust in healthcare providers, having a high level of psychosocial stress, reporting a high level of daily discrimination, where each of these factors were associated with a low kind of routine medical care use. So this was sort of in the setting of, these individuals perhaps feeling like they should be seeking out medical care, but those who were experiencing discrimination and these other factors were less likely to be seeking out and receiving routine medical care. And so if you're sort of wondering, when we think about this connection between discrimination and these health outcomes, how does this stress of discrimination potentially get under the skin, so to speak? How does it cause disease? And one theory around this, one mechanism really, is around this issue of allostatic load. And one definition of allostatic load is that it's the cumulative impact of physiological wear and tear that's related to maladaptive stress patterns that can ultimately predispose people to disease. I'm sharing with you here a model out of the coronary heart disease, coronary heart disease literature that really has similarities. Of course, some of these risk factors have similarities to what we see in kidney disease, but here, in this model of allostatic load, what's being noted is that early life events, early life sort of adversity, the social context that people are reared in and sort of experience as they develop into adulthood, their exposure to stress, that these can actually lead to changes in the epigenetic signature, sort of changes ultimately in the gene products that are sort of coming from these individuals, and can and also have impacts on their biological responses to stress, including inflammatory factors that may be released here, and can ultimately then lead to, in this case, this model is of atherosclerosis, coronary heart disease, and so forth. But certainly we can imagine that similar factors could play a role in kidney disease. So turning to this topic of residential segregation, which is where we'll kind of spend the balance of our time here. So importantly, residential segregation is, and here specifically thinking of racial residential segregation, is among the most potent forms of structural racism. And what we know is that what we see today in the United States with respect to residential segregation has been shaped by this historical practice of redlining. And for those less familiar, redlining was a discriminatory practice by which banks, insurance companies, and other sort of organizations in a position to make loans either to individuals or to businesses would actually refuse those loans or limit those loans to particular communities where, for example, if the community was one where the majority of the residents were Black individuals, these banks would be far less likely to make a loan to those communities than they would to communities where most of the residents were white people. And in many cities around the country, a similar practice was levied against predominantly communities where there were religious minorities, including Jewish individuals. And so I'm sharing with you now the redlining maps from the 1930s here on the left showing Denver. So I'll please take a moment and find where you live or where your friends and family live here on this map today. And on the right-hand side, I'm sharing with you the redlining map from the 1930s from Baltimore. As I shared with nephrology colleagues this morning, Baltimore in this time period, in this sort of the early 20th century, was regarded as kind of as a pioneer, so to speak, in this practice, this terrible practice of redlining, such that many cities across the country patterned their redlining practices after what was being done in Baltimore. And so what's being noted in the red areas, the redlined areas, are those communities that would be where it would be considered hazardous for these banks and insurance companies and others to make loans to, whereas those highlighted in green were those considered to be the most optimal or the best places for these banks to make loans to. So this is just sort of to highlight the red line community there. The Johns Hopkins Hospital sits very close to that star that's noted here in this figure. And so then importantly, if we fast forward to today, what we see in Baltimore is that even 5 miles actually makes a world of difference when it comes to health outcomes. When we look at a community that's in the northern part of the city, one called the Roland Park or Poplar Hill community, what we see is that the majority of the residents there are white individuals. There's a relatively high median household income at $104,000. There's a low unemployment rate and essentially a non-existent homicide rate. There's a high life expectancy for people who live in this community. And there's also a low death rate from heart disease. Whereas if we look just 5 miles to the southeast in the Madison or East End community, we see that around 90% of the residents are Black or African American. There's about a quarter of the median household income in compared to Roland Park. There's a very high unemployment rate. There's a high homicide rate, and there is a 15-year lower life expectancy in this community, where also there is a more than 3 times a greater death rate from heart disease. And so you may recall, this is the same community that I shared with you that had been redlined back in the early 20th century. And so importantly, racial residential segregation, as well, and certainly the practice of redlining, has enormous implications for individuals and their families to have secure places to live, so to have secure housing. And so this topic of housing insecurity is one that we've done some work with. This is work with my colleague, Dr. Tessa Novick. What we examined, so again, here in the Handle study, was to look at this question of housing insecurity and how it might relate to kidney disease. And we examined this question of, are you able to afford a home that's suitable for you and your family? And we found in this sort of sample from the Handle study that around a third answered no to that question, really indicating that they were likely experiencing housing insecurity. When we then went on to look at a number of different kidney outcomes in this population, what we found was that housing insecurity was associated with newly developing albuminuria, or incident albuminuria. In fact, people experiencing housing insecurity were more than 3 times as likely to develop albuminuria over the course of follow-up in this study. But housing insecurity wasn't associated with some of these other outcomes we looked at, like rapid kidney function decline or incident reduced kidney function or reduced GFR, which we think for those latter two may have been due to a relatively short follow-up. But here I think we were looking at around 4 or 5 years of follow-up here. But this study was able to provide one of the earliest looks at kind of this disassociation between housing insecurity and just developing kidney disease in the first place. In a related analysis, we then kind of focused in on people already with chronic kidney disease and thinking here about the patient population that we as nephrologists serve, and certainly these patients are being seen by all sorts of other clinicians. And we focused on around 350 people from the Handle study who had CKD and assessed similar questions around whether they could afford a suitable home, and also if they had had difficulties making rent or mortgage payments. And here identified that around 38% of this kind of CKD population had evidence of housing insecurity or housing instability referred to here. And then what we were curious about was, well, how does this experience that they're having, how does that relate to what we see in terms of care seeking for these individuals? And out of concern that if people are dealing with this challenge of housing insecurity, perhaps we're not even really getting to see them in the clinical setting as often as we would like to be able to manage their CKD and their other chronic conditions. And indeed, what we found was that there was this association, an independent association between housing instability and the postponement of medical care among these individuals who had CKD. And these were the way that the question around postponing medical care was framed for them was they were asked actually about postponing medical care, even if they otherwise felt like they needed to seek out care, really arguing that this is a significant challenge for these individuals. And so another thing that has been historically patterned by redlining is neighborhood food availability. In this study that published out of our School of Public Health, what they were looking at was the availability of healthy foods, fruits, vegetables, whole grains, low-fat dairy foods in stores across Baltimore City, which is noted here in the square that you see drawn there, as well as in Baltimore County, which are sort of represented by the areas outside of that square. And their major finding was that there was a greater amount of healthy food available in those communities where the residents were predominantly white, so indicated by the darker gray shaded areas, and the greater availability of healthy food indicated by the larger green circles here, in comparison to the predominantly Black communities, as well as there was a greater amount of healthy food available in the communities where the median household income was higher than in those lower income communities. And so another challenge that many of these same populations face is this issue of food insecurity. So not only just this idea of kind of the availability of these healthy foods in their community, but many also face overall, due to their economic circumstance, a lack of consistent access to enough food for an active, healthy life, or which is one definition of food insecurity. What we know in the United States is that non-Hispanic Black individuals and Hispanic persons actually experience a greater burden of food insecurity, and that food insecurity overall in the US tends to spike during times of economic downturn. So here, highlighting the this gray shaded area is the Great Recession, so in 2008 going into 2009. And of course, we've seen a spike in food insecurity in the setting of the COVID-19 pandemic. An estimate out of my home state of Maryland was that 2 million Marylanders were expected to experience food insecurity in 2021, and that represents actually a third of our state population. So when it comes to food insecurity and chronic disease, we know quite a bit actually about its relationship, food insecurity's relationship with chronic diseases, particularly those that have been regarded as being kind of diet related or diet sensitive chronic health conditions, particularly conditions like diabetes, where it's been well documented that people who have diabetes and are experiencing food insecurity have poor glycemic control. They're also at risk for hospitalizations for either hypo or hyperglycemia. We know that there's a relationship between food insecurity and hypertension. We also know there's a relationship between food insecurity and obesity. Particularly, this is seen in higher income countries where when those people experiencing food insecurity are able to access food, often it's these sort of energy rich, so highly caloric, but nutrient poor, right? Sort of unhealthy foods that people are accessing, which certainly can raise a risk of developing obesity. And then finally, my colleagues and I have done some work looking at food insecurity and chronic kidney disease. In one study, we, using data from NHANES, National Health and Nutrition Examination Survey, we were able to look at a population who had chronic kidney disease and assess whether if those individuals were experiencing food insecurity or not, what their long-term outcomes were with respect to going on and having that CKD progress to kidney failure. And indeed, what we found was that those experiencing food insecurity were more likely to progress to kidney failure during the 9 years of follow-up that we were able to do via this study. And then importantly, when we went on to kind of account or adjust for a number of different factors, I think we're excited, at least I was, to find that when we accounted for nutritional factors, that we were able to, at least statistically, explain away the sort of the statistical relationship, at least, or the significance of it, when we accounted for for these nutritional types of factors, really arguing that if even in the setting of these people who are experiencing food insecurity, of course, dealing with a number of different challenges, that if their actual nutritional status could in some way be intervened upon, that perhaps we could mitigate their risk of progression to kidney failure. And so this also came at a time when we were conducting some other work looking at different dietary patterns that had related to favorable outcomes with respect to kidney disease, including the dietary approaches to stop hypertension dietary pattern, as well as those dietary patterns that are low in dietary acid load. So here, thinking of the amount of acid that's presented to the kidney for handling. And what we know is that dietary patterns that are more rich in fruits and vegetables, for example, present less of an acid load for the kidneys to handle than do those dietary patterns that are more rich in animal-based foods, thinking here of meats and cheeses and the like. And so we were finding this through a number of observational studies. And but when we were thinking then, well, how could we, we're finding that these patterns are actually great for the kidneys. How could we begin to think about how to get them to the people who may really need this sort of intervention, so to speak? And one of the things that in some of our work to kind of look at the types of kidney protective measures that we often recommend to patients. So things like, sodium, lowering their sodium intake to less than 2 grams a day, and trying to achieve and maintain a normal BMI and be physically active, and to either not start or to quit smoking. What we found was that people who were in this analysis of the Handle study, what we found was that people who were either experiencing housing insecurity or food insecurity were about 18% less likely to be achieving all of these measures, right? These four, we actually looked at 6 different measures, but we were finding that this population was going to be less likely to be able to hit all of these measures. Really arguing that this would be quite a challenge to help them overcome these barriers that they may be facing with respect to either food insecurity or housing insecurity. So turning here to talk about interventions a bit. So we know that there have been some interventions in the kidney disease space that have been quite successful at really trying to address some profound disparities that we see. And I want to sort of lift up this one example that was a public health intervention addressing the profound sort of the very high rates of diabetes-related kidney failure, diabetes-related end-stage kidney disease, and thinking about how when we looked back in 1996, which is sort of on the far left-hand side of this figure, if we had looked at a national snapshot of which populations were experiencing the highest rates of of kidney failure due to diabetes, what we were finding is that the American Indian and Alaska Native population had the highest burden of this diabetes-related kidney failure. And if you look to the far right side of this figure, what you'll see is that that high rate of diabetes-related kidney failure was cut in half. It was cut by 50% by this time period, this 2013 time period. So how did that happen? So just highlighting those time periods. So most would argue that it happened as a result of this program set up by the Indian Health Services to really sort of improve upon the diabetes programming for this population, where if you looked at in 1997, very few of the clinics that were providing services to American Indians and Alaska Natives in this country were offering specialized diabetes teams, nutrition services for this population. Very few had culturally tailored diabetes education materials. Whereas in 2013, after this program had been launched for some time, you saw that the overwhelming majority of these services were being offered. And really, this is thought to be what led to that reduction by 50% when we look at these rates of kidney failure. Now, that I showed you data from 2013 and sharing here just to show that if you focus in on the gray line, that lower rate of kidney failure in this population has been maintained here in looking here again at 2018. Really, I think showing that it's possible through these types of services to actually mitigate some of these profound disparities that we see. And so when it comes to food insecurity, one of the things that a number of healthcare systems have done to try to intervene here is a number of different approaches that were summarized in this systematic review. What this review noted was that the majority of these systems that were addressing food insecurity, what they would do is to ask these questions to screen for food insecurity using the hunger vital signs questions, which include within the past 12 months, we worried whether our food would run out before we got money to buy more, and also included within the past 12 months, the food we bought just didn't last, and we didn't have money to get more. And if a patient answers in the affirmative to either of these questions, they would be considered to be experiencing food insecurity. And most of these healthcare entities would then document these food insecurity screening question results in the patient's electronic health record and continue to track it. And then most of them who identified people experiencing food insecurity would then refer those patients to food resources such as food banks, the federal benefit programs such as the Supplemental Nutrition Assistance Program, or the SNAP benefit that was previously referred to as the food stamp benefit program. Some of them would refer patients to medically tailored meal services where they could receive meals that really were tailored for their specific set of health conditions that were, in most cases, delivered to those patients' homes. And then some of them even had on-site food pharmacies or pantries. And so if the word pharmacy makes you think of medical, sort of medication pharmacies, indeed, this is what those systems were doing, where they would essentially almost write out the type of foods that would be recommended for an individual patient to consume. And then that patient would go and acquire those foods from an on-site within the healthcare system food pharmacy to be able to sort of consume that at their homes. And so we recently completed a follow-up on a clinical trial that really attempted to overcome a number of these challenges that I've talked about today that a number of populations, socially marginalized populations, experience. The trial was called the 5+ Nuts and Beans for Kidneys trial, and it built upon a successful 8-week study that my colleagues had conducted. In our case, we conducted a 12-month community-based dietary intervention for 150 low-income African-American participants who had both hypertension as well as albuminuria, and they had their GFRs at enrollment were 30 and above. So these were people with chronic kidney disease. And what we did was to test whether delivery of nutritional advice to follow a DASH-like diet plus $30 per week worth of fruits, vegetables, nuts, and beans, which are quite rich in potassium, and we're, in our case, we're supplied by a local grocer that we partnered with, could ultimately lead to a reduction in urinary albumin excretion, and also improvements in blood pressure. And so the results of our study will be forthcoming this year. We're sort of in the data cleaning and soon to be analysis phase here for the study. But I'm just sharing with you here the protocol, where we had two groups, with the group on the top there being our control group, so to speak, where they received just a brochure about the DASH diet, but did receive a gift card for $30 a week, so the same amount as the intervention group, but in this case, they were shopping on their own for these types of foods during the first phase of the study. And then in the second phase, they were just told to continue to follow this type of dietary pattern, but did not receive the gift card in that phase. Whereas in the intervention group, we did provide those groceries on a weekly basis, as well as they received brief coaching calls from a health coach around how to incorporate these types of foods into their dietary pattern. And then in the second phase, the food provision was no longer there, but they continued to receive periodic coaching calls. And so ours was a community-based participatory research study where we had numerous partners, including our grocer partner, ShopRite, as well as our community advisory board that's featured in the photo there. We've also done some work in recent work that we recently launched, partnering with an urban farmer to really examine the health impacts of this urban farm. It's set up in Baltimore City, where they have actually, it's called Plantation Park Heights Urban Farm. They've actually been providing food to 1,000 families a week via this farm, free of charge for those families. And we're doing some assessment of what the health impacts basically are of this program. Importantly, in many of our efforts, understanding that we will need to advocate for likely for some policy changes to really impact a number of these challenges surrounding the food environment, we conducted a study using a research discipline called photo voice, wherein participants are trained to use cameras to photograph something in their environment and then discuss those photos. We had participants, a group of African-American participants with hypertension, and many of them with kidney disease as well. We had them photograph their food environment, and then we have these discussions. And I'm sharing with you this poster that was made out of some of the key things that they highlighted in their discussion that we plan to use in our advocacy efforts with policymakers in Baltimore City and really in the state to try to really argue for some changes to improve the food environment. One of the things that we will certainly be highlighting is that in addition to these challenges in these environments, there are also some community assets that really could be bolstered through targeted efforts. One of the participants highlighted that that they would argue they would want health kitchens in our community, that thing we can do on our own, really, because we got the talent and the skill. And so something that I think is important, particularly in community-based research, is that we also identify and also sort of bolster those assets that communities have. And so to summarize what I've covered today, disparities in CKD are certainly profound, and they have significant societal impacts. Some of the root causes of these disparities include barriers to high quality healthcare, discrimination, and also the numerous downstream effects of residential segregation. And eliminating disparities in chronic kidney disease, in my view, and going on and achieving kidney health equity is really going to require us to address challenges that exist both inside and outside of healthcare, including some of the social needs that we talked about today, including housing insecurity and food insecurity. So I want to acknowledge the participants of the studies that I presented today, as well as my colleagues at these centers and teams whose work I shared today as well. And I want to thank you again. And again, I'm quite honored to be with you today. Thank you.
Dr. Cruz, thank you for that's just incredible talk. Really appreciate it. We have a lot of questions from the audience. We have a lot of how-to questions. I think people interested in how can they do these things in their environment. The one we get the most frequently, I think, is how do you engage with patients on these topics? And can you expand on the role of dietitians in your clinic? Is this something you do with all of your patients? And when they bring up these issues, do you have the resources to help them?
Mm-hmm. So first, thank you. So the first part of the question was how to engage with patients around this, right? Around this topic. So the first one, first approach, that I've taken, and certainly other people working in this area and pretty engaged in this area would take, is first just assessing, particularly in the context of providing dietary advice, which I think most of us do, right? Even if it's just to say, hey, you really need to cut down on the salt, which we sort of often do. That we first, before we even make a recommendation, that we assess whether or not this is someone who may be experiencing food insecurity. So you can use those hunger vital signs questions that I presented. And then one of the things that I've tried to do, particularly in people that I have a longer term relationship with, is to get a sense from them around what's in their environment. Sort of, questions about, well, where do you normally get your food? Like, where do you normally shop? Do you cook? That sort of thing, I think, is really important to understand the context in which they're living. I think the second part of your question was around engaging dietitians. So I think, unfortunately, we have, I think, as a country, we have inadequate access in most healthcare settings to dietitians. And that's definitely something in the kidney disease space that many are advocating for. Really, every CKD patient deserves to have a dietitian. But in our setting, what we do is we can refer patients to see a dietitian. I think that in addition to needing more dietitians, I think there needs to be continued efforts to make sure that dietitians are also kind of incorporating some of this consideration of context as well. And that in the kidney disease space, I would say, making sure that very up to date, I think, recommendations are given. For too long, we've told patients avoid sodium, avoid potassium, avoid these things. And, I would argue that the avoid potassium piece is really falling by the wayside now, especially now that we have newer potassium binders, for example. So we can really have patients have a liberal diet regarding fruit and vegetable intake for much longer in their CKD disease course than I think we have previously done. And so those are just some thoughts kind of around the dietitian piece.
No, those are great. The next question is related, and it sort of starts with the preamble is, what if we ask our patients questions that we don't have the answer to? And the question itself is do you inquire about housing insecurity and things that you necessarily can't intervene upon? And if you do, what do you do with that information when you get it?
Mm-hmm. So thanks for that. So yeah, I think a lot of these we as individual clinicians don't have the immediate ability to change, right? And so I think though we do have more of an opportunity than I think we often capitalize on. So one of them is the sort of linkage to resources. So even if that's making sure that they that our social worker colleagues that may be also engaged in our patients' care are aware of these needs that people are facing. Some healthcare systems are employing community health workers who are also in a wonderful position to be able to serve as that bridge to help connect people who are having social needs like housing insecurity to services that may be available for them. But I think so importantly, we need to assess it because we need to know because that can have implications for what we may prescribe for them, right? So a person experiencing housing insecurity is not someone who we should be prescribing a medication that they have to take multiple times a day, that they need to store in the refrigerator. We should be thinking we should be considering that their living conditions when we're sort of making those sorts of recommendations. So I think it's relevant to us, even if we can't change their housing status right away.
That makes good sense. I have a specific question came from the audience. It was about one of the slides I think you presented about a third of the way through that showed that progression of CKD is higher for people of African ancestry and Hispanic veterans, but mortality is lower. And how do you think about that data?
Yeah, I'm not sure. I don't know if that was the same. I don't know if it was in the VA data. Mm-hmm. I'm a little, yeah. I'm not sure if that showed, I'm not sure if I showed something on mortality there, but for sure in the in that VA study that I presented, their risk of the Black and Hispanic veterans' risk of progression was still higher than the white veterans, even though the Black and Hispanic veterans were more likely to receive nephrology care. Now I can't recall if that one mentioned mortality differences. We do see there's some interesting epidemiology, I would say, around disparities and sort of racial differences in mortality when it comes to CKD, and then it's particularly when we look at end-stage kidney disease. But I don't recall if that was on that slide or not. Maybe they could clarify in the chat if I missed something. But
if it gets clarified, I will. I'll pass it along here. And I know we're running short of time, but I wanted to ask one question. Our division head for general internal medicine has a question for you, which is, can you speak to your academic community partnership and how it is structured?
Yeah, so we enjoy a great relationship between so at our Center for Health Equity, we have a very engaged community advisory board that is comprised both of individuals who are patient advocates. They may have maybe themselves be living with some of the chronic health conditions that our research addresses, as well as some leaders in the broader community who are leading organizations like Farmer Chippy, who I highlighted there, who is the founder and lead farmer at Plantation Park Heights Farm. And so a key thing for our work has been the kind of mutual sort of shared development of these studies that we conduct, where we are not just sort of coming into the community and saying, hey, we want to do this study, we've already designed it, would you like to be a part of it? But rather we are together developing these questions. So my community partners are named in that U01 that funds the trial that I talked about. They're listed there. They will be co-authors, on the publications that come out. They help with presenting the findings and the like. So it's really a sort of shared governance of the work that we do together. And that's been really, really key to our work.
That's great. Well, it is a little bit after 1 o'clock. I want to be respectful of your time, Dr. Cruz. Thank you so much for joining us here today on campus and for Medical Grand Rounds. Really appreciate having your expertise.
Thank you so much. Really enjoy being with you.
Thanks.